Hi, today we will be talking about two aortoiliac disease, which is aneurysm and dissecting aorta.
Aortoiliac disease. If collateral circulation has developed, patients with a stenosis or occlusion of the aortoiliac segment may be asymptomatic, or they may complain of buttock or low back discomfort associated with walking. Decreased or absent femoral pulses may be experienced. For the medical management, the treatment is essentially the same as that for atherosclerotic peripheral arterial occlusive disease. Endovascular procedures such as bilateral common iliac stents may be attempted if the aorta has less than 50% diameter reduction. For significant aortic disease, the surgical procedure of choice is aortoiliac graft. Bifurcated woven or metadacron grafts are preferred for this surgical procedure. Nursing management for aortoiliac disease. For pre-procedural or preoperative assessment, you need to evaluate the brachial, radial, ulnar, femoral, posterior tibial, and dorsalis pedis pulses to establish a baseline for follow-up after arterial lines are placed in postoperatively. For postoperative care, you need to monitor signs of thrombosis in arteries distal to the surgical site. Assess color and temperature of the extremity, capillary refill time, sensory and motor function, and pulses by palpation and Doppler. Monitor vital signs, pain and intake and output. Abdominal assessment for bowel sounds and paralytic ileus. You also need to note any dusky or bluish discoloration, coldness, decrease in sensory or motor function, or decrease in pulse quality. Lastly, monitor urine output and ensure that output is at least 0.5 milliliters per kilogram per hour. For patient education, overview of the procedure to be performed, preparation for surgery, and anticipated postoperative plan of care. Aneurysm. It is a localized sac or dilation formed at a weak point in the wall of the artery. It may be classified by its shape and form. Characteristics of arterial aneurysm: true aneurysm, false aneurysm, and dissection. Thoracic aortic aneurysm. It is the ballooning of the upper aspect of the aorta above the diaphragm. Untreated or unrecognized, they can be fatal due to dissection or popping of the aneurysm that leads to nearly instant death. Thoracic aneurysms are less common than an abdominal aortic aneurysm. Abdominal aortic aneurysm. It is a localized outpouching or dilation of the arterial wall in the lateral portion of the descending segment of the aorta. It is most commonly located in the infrarenal aorta. Causes of aneurysm: heredity, trauma, atherosclerosis, high blood pressure, connective tissue disorders, infections, and tobacco use. Risk factors of aneurysm. The general risk factors are age, tobacco use, high blood pressure, buildup of plaques in your arteries, family history, Marfan syndrome and related conditions, and bicuspid aortic valve. And for abdominal aortic aneurysm are male and race. Pathophysiology of thoracic aortic aneurysm. Etiological factors like heredity, trauma, atherosclerosis, and such weakens the medial layer of the aorta that stretches forward and causes the outpouching of the aortic wall, and that forms the aneurysm. Pathophysiology of abdominal aortic aneurysm. Etiological factors degrades the structural proteins, which is the elastin and collagen, that causes inflammation and immune response of the body. Then the biomechanical wall stress and stretching of the inner and outer layers of the arterial wall occurs. It then weakens the middle layer or media of the artery. Then outpouching of the wall of aorta occurs, and that forms the aneurysm. Clinical manifestations. For thoracic aortic aneurysm, some patients are asymptomatic. Some patients may experience chest, neck, or back pain, dyspnea, cough, hoarseness, stridor, weakness or aphonia, and dysphagia. And for abdominal aortic aneurysm, the patient may feel the heart beating in their abdomen while lying, abdominal mass or throbbing, and back pain. The complications of aneurysm. They may be tear in one or more layers of the wall of the aorta and ruptured aneurysm. The different diagnostic procedures: chest X-ray, computed tomography angiography, magnetic resonance angiography, transesophageal echocardiography, ultrasonography, CT scan, and electrocardiography. For the management, control blood pressure and correct the risk factors. For the medications, beta blockers, angiotensin receptor blockers, and antihypertensive agents. For surgical management, endovascular grafting, open surgical repair, and endovascular aortic repair. For the nursing management, the patient who has had an endovascular repair must lie supine for 6 hours. Elevate head of bed up to 45 degrees after 2 hours. Assess vital signs in Doppler assessment of peripheral pulses every 15 minutes. Assess for bleeding, pulsation, swelling, pain, and hematoma formation. Monitor temperature every 4 hours. Report any signs of post-implantation syndrome. Notify the primary provider of persistent coughing, sneezing, vomiting, or systolic blood pressure greater than 180 millimeters mercury. Encourage the patient to drink fluids and monitor of pulmonary, cardiovascular, renal, and neurologic status. Nursing diagnosis for aneurysm. Anxiety related to sudden onset of illness, deficient knowledge related to unfamiliarity with surgical procedure and hospital care, risk for decreased cardiac output related to progressive dissection, and risk for ineffective tissue perfusion related to trauma. Lastly, prognosis of aneurysm. The prognosis or outcome depends on the size of an aortic aneurysm and its location. Additionally, it further depends on the overall health of the patient, the age, the gender, the value of blood pressure, and smoking habits. Dissecting aorta. It is a serious condition in which the inner layer of the aorta, the large blood vessel branching off the heart, tears. Blood surges through the tear that causes the inner and middle layers of the aorta to separate or dissect. The types of dissecting aorta. Type A. This is a more common and dangerous type that involves a tear in the part of the aorta where it exceeds the heart or a tear in the upper aorta which may extend into the abdomen. Type B. This involves a tear in the lower aorta only, which may also extend into the abdomen. The causes of dissecting aorta. High blood pressure, Marfan syndrome, atherosclerosis, and trauma to the chest. Risk factors of dissecting aorta. Hypertension, hardening of the arteries, weakened and bulging artery, aortic valve defect, and narrowing of the aorta at birth. Pathophysiology of dissecting aorta. Arterial dissections or separations are commonly associated with poorly controlled hypertension, blunt chest trauma, and cocaine use. Using of cocaine has a profound increase in sympathetic response that creates an increase in the force of left ventricular contraction that causes heightened shear forces upon the aortic wall that leads to disruption of the intima. Hypertension and blunt chest trauma results to mechanical forces that damages the aortic intima. The disruption of the intimal layer causes the dissection. A rupture may also occur through the adventitia or into the lumen through the intima. That allows blood to re-enter to the main channel and results to chronic dissection or occlusion of branches of the aorta. As the dissection progresses, the arteries branching from the involved area of the aorta shear and occlude. The dissection of the aorta may progress backward in the direction of the heart. That then obstructs the openings to the coronary arteries, produces hemopericardium, aortic insufficiency, or it may extend in the opposite direction. That results in the occlusion of the arteries that supplies the gastrointestinal tract, kidneys, spinal cord, and legs. Clinical manifestations of dissecting aorta. Chest, abdominal, leg or back pain, pale, sweating, tachycardia, elevated blood pressure, dyspnea, fainting, weakness or paralysis on one side of the body, trouble speaking, and dizziness or confusion. The complications. Dissecting aorta may lead to death, organ damage, stroke, and aortic valve damage. The different diagnostic procedures. Arteriography, multi-detector computed tomography angiography, transesophageal echocardiography, duplex ultrasonography, and magnetic resonance angiography. Nursing management of dissecting aorta. The patient who has had an endovascular repair must lie supine for 6 hours. Elevate head of bed up to 45 degrees after 2 hours. Assess vital signs in Doppler assessment of peripheral pulses every 15 minutes. Assess for bleeding, pulsation, swelling, pain, and hematoma formation. Monitor temperature every 4 hours. Report any signs of post-implantation syndrome. Notify the primary provider of persistent coughing, sneezing, vomiting, or systolic blood pressure greater than 180 millimeters mercury. Encourage the patient to drink fluids, and monitor pulmonary, cardiovascular, renal, and neurologic status. The nursing diagnosis of dissecting aorta. Decreased cardiac output secondary to progressive dissection of the aorta. Acute pain related to decreased myocardial blood flow. Ineffective tissue perfusion related to compromised arterial blood flow. Lastly, the prognosis of dissecting aorta. For aortic rupture, in which all three layers of the aorta are disrupted, the mortality rate is up to 80% of patients. 40% of these patients die before reaching a hospital. For type A aortic dissection, the mortality rate remains high, with up to 30% death rate after surgery. Type B aortic dissections treated medically have an initial death of 10%. This compares with 25% mortality when treated surgically. Overall, for both types of aortic dissection, the 10-year survival rate is more than 60%.
Thank you for watching.